A health consumer advocate is a very broad term because it covers a wide spectrum of people. So you can have the individual who comes along with a family member when they've just been given a very poor prognosis, a really bad diagnosis, and that patient is in a position where they can't actually make an informed decision. So you'll often get a family member coming to listen to what has to be said about treatments, and then making sure that the patient doesn't make a decision without having thought about all their options. On the other hand, you could get someone who has qualifications in a health discipline who actually can take a patient, and they should be really unbiased in the sense that they're treatment agnostic. So they have to put the patient first, find out what the patient wants, and then look at the options that are likely to help the patient get to where they want to be. For about 20 years I've been a patient advocate, and I suppose in my practice I get many people who need to integrate both medical conventional treatment plus more complementary therapies. And the difficulty here lies in trying to navigate not just the treatment options, but how the patient actually navigates the health system so that they can get the best information from their main health practitioner. For me, I get a lot of personal satisfaction that a patient is actually making informed decisions so that they are not living with regrets, that they're making a decision that they feel that they haven't been pushed into, that it's been considered, and then they very often, by taking the reins of their health, we actually see really good outcomes and really good collaboration, and then that means that everybody is satisfied. Yes, I mean, I had one young woman who came to me, and she had a very complicated case, and she'd seen many different practitioners in conventional medicine, and it was proving very difficult to get the treatment that she needed because there was a peer pressure within the industry, and also their procedures. She didn't quite fit into those particular pathways that they were pointing her in. And we'd worked out that had she gone down those pathways, she wouldn't have actually been able to achieve the outcome that she wanted. So it was a long process over a period of probably 5 years, but we gradually worked our way forward, and in the end we got all the practitioners that she needed on her team on side, and we got the most fantastic outcome. Well, this young woman was unable, she was in a lot of pain all the time, and she was unable to hold a job down. She was unable to fulfill a career because she was unreliable, and she was unable to enter into a good relationship with a partner because of her circumstances. And for that young woman, the outcome meant that she could follow her career because she was pain-free, she could have a partner, and she could actually have a life, because prior to that she didn't have a life. So, you know, what more? That's what it's all about, is to get the best quality of life that you possibly can for a patient along their criteria. For this young lady, it would have been years and years and years of medication. It would have been a deteriorating health which no one was questioning. She would have been unable to earn, go to work, so she would have been dependent on benefits. So from a cost perspective, actually getting the treatment that she needed, it would be huge cost savings. Okay, well, if we start with patients first of all, patients are really what we call, or how I would identify them would be passive recipients of the health system. They have a lot of trust in their doctors' decisions. They don't feel that they are equipped to make decisions because they're not medically trained. So they're happy to actually give the responsibility over to someone that they trust and go along with whatever recommendations they're making. A health consumer is someone who, I wouldn't say that they've lost trust, but they actually want to make an informed decision, and they don't believe that they are not equipped. You know, they're knowledge workers, so they will use the internet, they will research their condition, and very often they know more about their condition than their physician. So they'll want to have some sort of collaborative working relationship, and they will want to make decisions based on their own individual risk factors and their own criteria of where they want to end up. And a lot of these health consumers don't want to become drug dependent for life. So when they're offered a pathway that could mean that, they want to actually hold the reins and say, wait on a minute, let me see if I can address some of the causes of my condition so that I'm not drug dependent. So they feel confident to make those decisions. Well, they will have done their research and gone on. There's a lot of good internet sites, so they can learn about the condition, the symptoms, all the treatments, and they will have balanced their own case against that. But they will also have looked at the causes and the risk factors for that. So they are very knowledgeable all round, whereas a physician may just be looking at the symptoms and the diagnostics from a procedural point of view. The patient is then given that procedure to follow without factoring in any of the individual risk factors that health consumer may have. So a physician may know a lot about a condition, but they may not know more than the patient against the background of that patient's case. People who come to see me, they experience enormous friction when they try and collaborate with the health system. Their physicians often don't have the time to listen to them or even discuss, and there's an inflexibility about the procedure because they're trained to follow those certain procedures for specific diagnoses. I mean, I had one lady who had cancer, and she had a big tumour she had bowel cancer, big tumour, and they said to her that they wouldn't proceed with surgery unless she had the chemotherapy and radiotherapy first. Now, she understood that. She wasn't opposed to that, but she actually didn't want to have the high-dose chemotherapy that was being offered in this country. So we did our research, and we phoned abroad, and it went to Germany in the end, and she had a low-dose chemotherapy that was coupled with hypothermia. And she shrunk her tumour from 8 centimetres to 2 centimetres. And she came back for the surgery, and she was told that they wouldn't offer her the surgery unless she had their chemotherapy. Now, that to me is total non-collaboration in a completely inflexible system. Generally, a patient needs to talk about their strategy with the medical health person, whether it's a surgeon or an oncologist. So they need to create dialogue where the practitioner is not, they need to create a dialogue where the practitioner understands that the patient is making an informed decision, that they're not doing it because they've read something on the internet. And the patient also needs to make sure that their practitioner understands that they know the risks. They know that if they follow what they want to do, what those risks could be, as opposed to doing what the specialist wants them to do. So there is opportunity for that dialogue. And I also try and say to patients or health consumers to keep on your side of the fence. Don't get embroiled with the science and the statistics, but just say it or explain to the practitioner how their condition affects them, what it means to them in their life to have that condition, what their fears are, what their concerns are. Because once you start communicating on that humanitarian level, you're much more likely to be able to speak the same language. So you're not talking in medical terms, you're just talking about your own fears, the potential consequences and how that's going to affect your life, and where you're coming from as a human being in making those decisions. When health consumers, let's say they have a diagnosis of cancer, and then they're faced with treatments that they don't really want, and they're given the statistics. If they do the treatment, you can have a 85% survive 5 years without the disease coming back, and if you don't do the treatment, 15% survive. For a patient, that's a massive difference, and obviously they're going to go along with what the consultant is advocating. But in many cases where a patient has a chronic disease, they actually want to know what their odds are. So they may be presented with statistics, and the doctor may say, if you take this drug, we can reduce your risk of, say, heart attack by 33%. Well, a patient may think, wow, that's really, really good. But then when they come and have a look at it and have a look at the research, they may find, when they look at the absolute statistics, that they may only reduce their risk of heart attack by 2%, because what they're measuring is the difference between the number of people who had a heart attack, not the people who remained healthy. All right, so you could have, say, in one arm or the control group, 100 people who have certain risk factors for heart attack. 6% may have a heart attack. But in the trial group that are taking the drug, only 4 people have a heart attack. That's a reduction of 2, or 33% of the 6. And so then the patient often says, well, we can work out the odds from that, because if you have the absolute statistics, you can. So when the patient actually looks at the absolute statistics and turns it into what are my odds if I take this drug, it's a 1 in 50, which means that your odds of avoiding a heart attack if you take that drug for 5 years are just 1 in 50. So a patient may then say, well, let's look at the risks of the drug. And if then looking at the risks against the benefits aren't that great. The patient may decide, well, maybe I should address the causes of why I've got those risks, why I might have a heart attack. And then, of course, you're really getting somewhere, because those patients actually do want to take self-responsibility. We are talking about a meeting point, but what we have to do is we have to reverse the existing model on it. We have to turn it on its head. The existing model is where the practitioner or the health system generate fear through the susceptibility of the patient to the risks and the severity. Then they talk up the benefits of the treatment, so it reduces the barriers in the patient for rejecting that treatment. However, if you reverse that and you say, what is it about these consumers that we can leverage value from? It is their self-efficacy. It's their confidence to actually make a difference, and that they feel that they can actually deal with their health situation and get a better outcome. Once you harness your message to that, you're actually building confidence into the consumer, and you will by default get better health outcomes. It's going to be much cheaper, because what you're looking at doing is you're uncovering the cause of the condition, and most of our chronic diseases are due to lifestyle. It's what we eat and our lifestyle habits. Once patients really begin to understand the impact of that they then get a commitment to actually start changing some of those things, and as a consequence of that, their health changes. So it's generating the confidence in the health consumer that they can actually make a difference. It's doable, which of course is the reverse of consumers today, or the system today. It generates a fear that if you don't do what I say, then you're going to get worse. That means that it's going to cost more. So really, if we leverage off that characteristic, we could start to see the reduction of vast amount of chronic disease, diabetes, cancer, osteoporosis, you know, all the big problems that cost so much money. Yes, I've had quite a few patients who've worked with their health professionals while they've been coming off the medications that they've been prescribed, and as long as the patient works out the strategy with the doctor, so the doctor is on board, and the doctor can give them a window of opportunity, and he will say, we need to monitor because I'm happy about it. I think that you do have time. If you can make these improvements, then we can lower the drugs. You come back in 6 months or 3-month intervals. So if the GP can feel involved in that journey and the patient isn't at risk of having an acute crisis, then yes, we can get really good outcome.